Good evening, everybody. So, in spite of we understanding about the harms of, in spite of we understanding the harms of conventional ventilation and the usefulness of non-invasive ventilation, I think all the NICUs have ventilators. We cannot go away with the fact that invasive ventilation is a part and parcel of NICU care. And to learn about this, and we would want to have as minimal ventilator-induced lung injury as possible. So to learn about all these things, about how to optimize the ventilation and how to define the lung protective strategies, we have an excellent talk today by Dr. Keszler. He is from Czech Republic and he has graduated. Can I have his introduction? He has done he's graduated from McGill University, Montreal. He is the professor of pediatrics in Brown University and also the director of respiratory services at the Women's and Infant Hospital of Rhode Island. He is a seasoned clinical trialist who led several multi-center randomized clinical trials of various modes of respiratory support that have importantly impacted the clinical practice. He is also one of the investigators of the NIH-funded Neonatal Research Network, and he is also a very active educator, author, and editor, including the just released 7th edition of Assisted Ventilation of Neonate. He is on the board of the directors of the Hippocrates Foundation and is responsible for the respiratory seminars. His areas of research interest include the volume targeted ventilation, delivery room stabilization, high frequency ventilation, pulmonary hypertension, BPD, ECMO, and PINO. Now, may I request him to start his talk?
So thank you very much for that kind introduction. It's my pleasure to share with you in a very short period of time some key concepts about how to avoid lung injury as best as we can. And as you heard, we can't always do that, but we try. So let's see if we can, I'm assuming everybody can see my slides, okay?
Yeah.
Yes, very good. So I want to begin with the key concept, which is that ventilators are nothing more than tools in our hands. And while the manufacturers have come up with some very sophisticated devices, they're not, the machines themselves are not inherently lung protective, no matter how good the tool in our hands is. If I do not use that tool the right way, if I use it for the wrong job, the result will not be as good as it could be. So we need to understand what we're trying to achieve. We need to understand the pathophysiology, and we need to focus on our individual patient because they're not all the same. So the other concept that's important is that BPD, the ultimate pulmonary outcome, is affected by a whole host of factors. Pathogenesis is very multifactorial. And of course, injury to the lungs may begin already in utero with inflammatory problems related to corium neonatis. Growth restriction and oligohydramnios cause the lung to be hypoplastic at the moment of birth and more susceptible to injury. preterm delivery and the initiation of air breathing are critical time where lung injury can occur very rapidly. And as I said, there are all these other factors that play a role. We don't have time to cover all of them, but the key message here is that prevention of lung injury really has to be a package deal. It has to be a bundle of interventions to try to minimize the bad outcomes. So our preterm infants are at a disadvantage at the moment of birth because of all these factors listed at the top of this slide. Preterm infants have excessively compliant chest wall, which lacks the rigidity to expand the lungs and keep them expanded. They have limited muscle strength and endurance. They often are born by cesarean in the absence of labor, so they have more fluid in their lungs to begin with. And they often have some respiratory depression. So they have a limited ability to establish and maintain functional residual capacity. And so we must do something to help them achieve that important goal so they can effectively exchange gas. But it turns out that it is very easy to injure the lungs in the early moments after birth. These are some very old data from an animal experiment where animals were exposed or not exposed to 6 rather large tidal volume inflations after being given surfactant. And you can see that in the control animals that did not receive the injurious ventilation, there was a nice improvement in compliance, as you would expect. But the animals were large tidal volumes caused capillary leak and acute edema. The surfactant effect was essentially eliminated. So it is, again, very easy to incur damage in the first minutes of life, and that's why we talk about the golden first hour, among other reasons. So because of the problems with insufficient chest wall rigidity, use of positive pressure with end expiratory pressure, or CPAP, in spontaneously breathing babies is critical in facilitating the establishment of functional residual capacity. These are studies done a number of years ago with phase contrast radiography, where air is white. And you can see that these animals that were ventilated without PEEP, there was really no FRC. There was no aeration at the lungs at end exhalation, and very little and rather uneven aeration after 20 positive pressure inflations, even at peak inspiration. Whereas with some reasonable level of PEEP, and 5 is probably not enough for most babies, there was a reasonable amount of air within the lungs at the end of exhalation, and the lungs were nicely aerated, evenly distributed after 20 inflations. So PEEP, if you're using positive pressure ventilation, or CPAP in babies breathing spontaneously, is critical to establish adequate lung inflation, which I will talk about later, is critical in avoiding lung injury. There was a lot of interest in sustained inflation, a process that exposes babies to a prolonged inspiration, typically 10 to 15 seconds. The rationale being that fluid is more viscous than air, and it takes longer inspiratory time to effectively move fluid through small airways. There's a lot of interest in that in Europe, but the data were inconclusive. So Harish Kirpalani and I, as well as Peter Davis, got together and did this large randomized trial, which is the last study here that was added to the updated meta-analysis. And clearly, there is no particular benefit, certainly not in survival. In fact, the trend is away from sustained inflation, and there was no benefit in terms of reduction in chronic lung disease. And therefore, the sustained inflation enthusiasm has rapidly faded. We, of course, know that the best way to avoid ventilator-induced lung injury is to avoid mechanical ventilation and use non-invasive techniques. I'm not going to focus on non-invasive support because of lack of time. I think we all know they're effective in most of the more mature babies, but the extremely preterm infants, less than 28 weeks, do not succeed as often, at least in this study from 2016 from Australia. The folks who do bubble CPAP really well would argue and seem to be able to demonstrate that they have good success with non-invasive support down to as low as 26 weeks gestation, at least initially. Although ultimately, and this is the ultimate avoidance of positive pressure ventilation, many of those babies ultimately do end up being intubated. So it is inevitable that in some of the more immature babies, we will have to intubate and subject them to mechanical ventilation, which we know is potentially injurious. So we have to choose some settings, and the first choice we need to make is what form of synchronized ventilation we should use. And we need to keep in mind that with synchronized ventilation, the tidal volume that results is the sum of the positive pressure from the ventilator, shown in green here, and the negative inspiratory effort of the infant, which is not seen on the ventilator waveform interface. It is not measured in the pulmonary graphics, but it is there. And babies who are premature, as you know, have irregular respiratory effort, sometimes apnea, sometimes periodic breathing. So it makes it more challenging, and they don't have a lot of strength. So they often, breathing through narrow endotracheal tubes, don't generate a very strong, a very large tidal volume. And so if you were to use SIMV by itself, you would have the following problem. And what I've done here are the positive pressure inflations, and here in red below the line is a negative inspiratory effort of the baby. So synchronized, so this tidal volume is going to be quite large because it's the ventilator and the baby working together. But in between, the baby is breathing spontaneously. And if you're not using pressure support, the tidal volume often is insufficient to even clear the anatomical dead space. And this is essentially rebreathing dead space does not contribute very much to minute ventilation. So this is probably not the way to ventilate babies. Personally, I favor assist control of pressure support as a primary mode. But if you were to use SIMV, you would at least want to use it with some pressure support. And this is shown here. Again, very much the same breathing pattern of the infant. But now we have added, apologies, this is jumping on me. Now we have added some positive pressure support, so that the tidal volumes become more adequate and easily clear dead space. So it's important to recognize that breathing through a narrow endotracheal tube really handicaps our extremely small infants. And because without adequate pressure support, there are only a relatively small number of positive pressure inflations, the tidal volume with SIMV ends up being larger and more injurious than with assist control, and that's been pretty well documented. How much pressure support to use? Well, the point is to get adequate tidal volume, so it should be titrated. It shouldn't always be 6, as some people do. 6 may be a reasonable starting point, but then you have to look at what tidal volume you're achieving with that pressure support, and if it's still not at least 3.5 to 4 ml per kilo, then you need to increase your pressure support. Of course, I have for a number of years advocated volume-targeted ventilation as an important lung protective strategy. And I will show you some evidence that it's excessive tidal volume rather than pressure that matters most in terms of lung injury. You know that hyperventilation occurs frequently and is not easily avoided with pressure-controlled ventilation. And we know that that's not good for the brain and the lungs. And you also may be aware that the traditional adult type of volume-controlled ventilation doesn't work very well in newborn infants for reasons I'll briefly explain. So here is one of many studies that have looked at this issue, and what they did in this study is they took a bunch of small animals, they exposed them to progressively higher inflation pressures. These animals had healthy lungs. And in half of the animals here in the filled bars, the black bars, those animals had a tight plaster cast placed around the chest and abdomen to restrain chest wall movement and therefore limit tidal volume. And they look at capillary filtration coefficient, essentially an index of acute lung injury or lung edema. And at 15 centimeters of water, not much happened. It's a low pressure, doesn't overexpand the lungs, doesn't injure anything. At 30 centimeters of water, there was already a significant increase after a rather brief period of mechanical ventilation. where the lungs were free to move, no change when the plaster cast limited tidal volume. It's not surprising that in these animals with normal lung compliance, a pressure of 45 resulted in a vast increase in lung edema. What is surprising is that the animals in whom tidal volume was constrained did not show any such increase, suggesting clearly that it is excessive tidal volume, not the pressure by itself, that causes the acute lung injury. And so this and many other studies essentially tell us that the adverse consequences of inflation pressure, of high inflation pressure, are mediated through excessive tidal volume. And if the pressure does not result in distension of the lungs, you do not see that injury. So because we were historically very concerned about the effects of pressure, and because we use uncuffed endotracheal tubes, and because when we initially tried volume controlled ventilation with adult machines in the 1980s, it didn't work very well. We all defaulted to pressure controlled positive pressure ventilation, which in its basic functionality is nothing more than a mechanical T-piece resuscitator, which we're all familiar with. And so if you're in an SIV mode during the expiratory phase, there is continuous flow of gas through the circuit. There's a PEEP valve maintaining distending pressure, and the patient can breathe in and out spontaneously. And when the ventilator cycles on, the expiratory valve closes, the circuit's pressurized, and gas enters the lungs in proportion to the pressure in the circuit and the compliance of the lungs. And we're not worried about leak around the endotracheal tube because there's plenty of fresh gas to compensate and maintain the desired lung inflation. So this is easy to use, and we felt that it was really important to control the pressure. Barophobia has persisted to this day, but it's probably misguided. The problem with pressure-controlled ventilation, of course, is that compliance can improve rapidly. When babies first come out, there's a lot of fluid in the lungs. They may not have established adequate FRC. They have not yet received their surfactant. Then all of that changes. We have rather effective animal-derived surfactants that rapidly improve compliance. Baby clears their lung. We apply adequate distending pressure. And all of a sudden, the baby moves from this flat portion of the compliance curve where whatever pressure we were using may have been just about right. And then suddenly that same positive pressure results in a much larger tidal volume. And this can be quite injurious. So we don't have a single large randomized trial, but we do have a series of smaller studies that amount to a total of almost 1,000 infants studied. And this latest meta-analysis demonstrated a strong trend, but not quite significant in the combined outcome of death or BPD at 36 weeks. The point estimate was 25% reduction, but the confidence intervals cross one, so not a significant difference. But BPD as the primary outcome was reduced by 27%. And the confidence intervals now are clearly to the left of the line of unity. They do not cross one. And a rather impressive number needed to treat of only 8. So this is nothing else makes this much of an impact on chronic lung disease, to my knowledge. Severe interventricular hemorrhage and interventricular hemorrhage plus or minus PVL were reduced by about 50%, again, statistically significant, with a number needed to treat of 11. Pneumothorax was reduced by about 50%. Less common events, so number needed to treat is a little higher. Hypocapnia was reduced by about 50%. And because it is a common event, only 3 babies need to be treated to avoid 1 instance of significant hypocapnia. And duration of mechanical ventilation was reduced by a little more than a day. So these are all pretty impressive outcomes, suggesting that we really should be doing this. So I just want to point out the difference between volume controlled ventilation and volume targeted ventilation. Volume controlled ventilation is the adult style of ventilation, where a fixed tidal volume is injected into the proximal end of the ventilator circuit. This is In other words, volume control ventilation controls what enters the patient's circuit. It does not control what enters the patient's lungs. That's an important distinction. In larger subjects without an endotracheal tube leak, this works just fine because the lungs are large and more compliant than the circuit. But when you have a tiny baby attached here and when you have an uncuffed endotracheal tube, there's a lot of loss of volume to compression of gas within the circuit, leak around the endotracheal tube, so that you may have to set a tidal volume of 10 or 12 ml in order to achieve an effective tidal volume entering the lungs of around 4 ml. This, of course, is variable. It's not a constant relationship. And leakage is, of course, also highly variable. So this did not work very well. And that was the main reason why we all reverted to pressure controlled ventilation. But now we have a more sophisticated approach, which is what I refer to as volume targeted ventilation. There's some confusion in the literature. Some people refer to volume targeted ventilation as anything that pays attention to tidal volume. But the way I use it is pressure controlled ventilation with automatic adjustment of inflation pressure. So it's still pressure controlled, but instead of manual adjustment to the inflation pressure, we make those we let the ventilator make those adjustments automatically and in real time. So after initial inflation or two, the tidal volume is measured. It's compared to the target, and if the tidal volume measured is less than target, inflation pressure will go up for the next cycle. If it's within a few percent of the target tidal volume, no change. And if it's above the target, the inflation pressure will be reduced for the subsequent cycle. And we have some pretty good evidence, as I showed you, that this is beneficial. And it's been shown, among other things, by us and others, that you maintain a relatively constant tidal volume. There is some fluctuation because the baby's contribution to the transpulmonary pressure is variable. It's a good thing because completely monotonous tidal volume leads to atelectasis. But the most important thing is prevention of overdistension, of volutrauma and hypocapnia when we do the things we do to help the baby improve their lung compliance, which can happen very soon, very rapidly soon after birth or after initiation of mechanical ventilation and administration of surfactant. Equally important is the fact that the ventilator lowers or adjusts inflation pressure in real time. It doesn't wait for the next blood gas. It doesn't wait for morning rounds. It doesn't worry that the professor will chastise it for making the wrong decision. It does what it's programmed to do and leads to more rapid weaning from mechanical ventilation. And finally, it also compensates for the highly variable respiratory drive of an immature infant who has a lot of periodic breathing and brief periods of apnea. And volume targeted ventilation will make that adjustment in real time. So that's one half of the equation. But the other important element of volume lung protective support is to make sure that that tidal volume, which we so carefully control, is evenly distributed into a well-aerated open lung. And that may be a confusing statement, so let me clarify. We think of RDS as a homogeneous disease, and on a plain chest X-ray, it looks rather homogeneous. But that's because a three-dimensional structure is being compressed into 2 dimensions. And if you cut the lungs crosswise with a CT scan or MRI, or these days with electrical impedance tomography, you will see that much of the atelectasis is concentrated posteriorly in the dependent portion of the lung, and the aerated lung is in the non-dependent portion of the lung. And when you ventilate a lung that looks like this, you of course will have a relatively high oxygen requirement due to ventilation perfusion matching, and that's in itself is toxic. But there's a complex process of atelectrauma going on with surfactant inactivation, increased surfactant turnover in the allectatic portion of the lung, with shear forces causing acute mechanical injury at the boundary, with portions of the lung that are expanding within each inflation and collapsing at end exhalation, which we know is very injurious. And finally, we have the aerated portion of the lung, which it turns out receives the bulk of each tidal volume. Why? It is because, as you recall, Laplace's law tells us that the pressure needed to distend a balloon or alveolus is inversely proportional to the radius. So the critical opening pressure of these collapsed alveoli is higher than the pressure needed to overexpand the already aerated larger air sacs. And consequently, this relatively healthy, non-dependent portion of the lung is where most of the lung injury will occur, with volutrauma regionally focused over here. And we actually have experimental evidence to tell us that this is in fact true. This is, again, not new data. Here, the investigators lavaged some animals and used what they described as non-injurious ventilation, which was an open lung strategy. So they avoided that problem. And injurious ventilation was where they did not recruit the lung adequately. So the situation that I just described. And what they saw, looking at hyaline membrane score and histologic measures of lung injury, the non-dependent region of the lung is where most of the lung injury was. Again, here as well. When you look at biochemical markers of lung injury, cytokines, etc., again, most of the injury was in the non-dependent regions of the lung. So this is a real phenomenon, and we need to do something to correct the problem. If we're starting over here with poorly aerated lungs on the pressure volume loop or relationship, we're here on the inspiratory limb. The aeration is poor, compliance is poor, indicated by the relatively flat slope of this compliance curve, and of course high oxygen requirement. And the trick is to increase our mean airway pressure. With oscillatory ventilation, it's easy to do by directly increasing mean airway pressure. With conventional ventilation, it's essentially occurring by increasing end expiratory pressure along with some increase in PEEP. Inflation pressure does need to reach the critical opening pressure, at least briefly, and then end expiratory pressure maintains it. And the idea is to move up to full lung inflation, and there will be some overexpansion of the lung when we reach this full open lung. And now we are in a situation where, having inflated the lung, it becomes more compliant. Recall again Laplace's law. So these alveoli now need less pressure than they did when they were collapsed. And the idea is to reduce the distending pressure and find the sweet spot just above the de-recruitment point over here. And now we have a relatively nicely inflated lung. We can now actually see this in real time with electrical impedance tomography, which is still a research tool, not readily available at the bedside for most of us. But you can really see that this phenomenon is occurring. And this hysteresis of the pressure volume relationship is very key. And we like to ventilate on the expiratory limb of the pressure volume relationship over here. So alveolar stability is a real issue. The collapse and re-expansion of alveoli is very injurious. The healthy lung does not have such a problem. The alveoli are stable. When the lung is injured and surfactant deficient, the problem is alveoli collapse. One way to avoid that is high frequency ventilation. Oscillatory ventilation avoids spending any amount of time at the end expiratory pressure, and it's been shown to maintain alveolar stability, as seen here. But it turns out that you don't need to, that it's not, the benefit is not limited to oscillatory ventilation. The benefit can also be achieved by using adequate end expiratory pressure. So PEEP is very much protective. PEEP, adequate PEEP, with adequate lung recruitment maintains lung volume and avoids that atelectrama we talked about. Here is a very old study that shows that when ventilating, even for a relatively brief period of a couple of hours with no PEEP, this is just looking at pressure volume loops after period of ventilation. This loop is clearly abnormal. 4 centimeters of PEEP may be not quite as bad, but still bad. With sufficiently high PEEP, in this case, they define it as being above the lower inflection point. Clearly, PEEP was protective. And there's many other examples of that. I don't have time to show you that. And here is evidence that lung protective ventilation is possible even with conventional ventilation. So here is a group of animals ventilated after being lavaged with warm saline to remove surfactant, ventilated conventionally with large tidal volume and low end expiratory pressure, very high lung injury score, with oscillatory ventilation using the open lung strategy, a great reduction in that acute lung injury score. But here is a group of animals ventilated at conventional rates with adequate end expiratory pressure and showing similar degree of protection. So end expiratory pressure is important in maintaining alveolar stability and avoiding lung injury. But there's no simple recipe for PEEP because there is no single level of PEEP that's optimal for all infants or even for one individual infant at all points in time. It's a dynamic scenario. The idea is to, of course, is to titrate PEEP to optimize lung volume. We do not paralyze our babies, so they breathe and they take spontaneous large recruiting size on their own. So for most babies who are awake and breathing, PEEP is what's needed to facilitate lung volume recruitment. And because we don't all have access to EIT, we use oxygen requirement as a proxy for ventilation perfusion matching, which is, of course, a proxy for optimal lung inflation. So the idea, if you have acute RDS, we titrate the PEEP up until the FiO2 comes down, typically down to less than 30%. Once the FiO2 is down, we need to again recognize that the lung now has become more compliant. If we have just given surfactant, the lung becomes more compliant. So it's equally important to come down on the PEEP once the lung becomes well recruited, because excessive PEEP can be damaging, but not enough PEEP is equally harmful. So we need to be vigilant and maintain the appropriate level of PEEP for an individual patient at any given point in time to be truly lung protective. Of course, the exception to the sort of usual levels of end expiratory pressure, which range from 4 to maybe 8, sometimes a little bit higher. Older infants with BPD need much higher end expiratory pressure for different reasons we don't have time to go into. And so, let's briefly talk about how we should initiate mechanical ventilation. So you have read all the books, you have listened to all the lectures, so you understand that you need to tailor your strategy based on the pathophysiology of your patient. You choose the settings you believe are correct for your patient. And typically for many people, this is the end of it, and then they get a blood gas, forgetting this really important step, which is to evaluate the patient's clinical response, because they're not all the same. And all the target tidal volumes described in the literature, they have a standard deviation around them. One size does not fit all. So we need to look at the patient, and then blood gas only confirms what the baby was telling us, and that the adjustments we made in response to the baby's clues are appropriate. And so what are those? So babies can tell us a lot if we understand their language. So if, for example, initiated mechanical ventilation, maybe you just gave some surfactant, and the baby who is breathing actively stops breathing after 10 or 15 minutes. That probably suggests that we have taken away their respiratory drive, and we need to make an adjustment to the target tidal volume, or if you're on a different modality, perhaps the rate. If the baby becomes tachypnic or remains tachypnic with retractions, the baby is clearly telling us that the support is inadequate, and we need to respond to that, not wait for a blood gas. You should be able to tell clinically if the baby is not receiving adequate support. If the baby's oxygen requirement is rising, we probably have a problem with insufficient mean airway pressure and diffuse microatelectasis, so we need to adjust the PEEP. And my favorite, babies fighting the ventilator. And some people say, oh, the blood gas is bad because the baby is fighting the ventilator, so let's paralyze him or give him some morphine. Actually, the baby who's fighting the ventilator is struggling for breath. They're air hungry. They're telling us something, and they can't tell us exactly what's wrong, but it's either grossly inadequate support, perhaps is unobstructed endotracheal tube, maybe the tube is down in the right mainstem bronchus, the baby's head is turned and up against the wall of the trachea. Something is seriously wrong, and we need to figure out what it is, look at the waveforms, look at the baby, and correct that. Drugs only mask the baby's response to inadequate support. They don't correct the problem. And finally, what about high frequency ventilation? I will go through this quickly. As you know, early studies of high frequency did show benefit over simple, primitive, and intermittent mandatory ventilation with no synchrony and no effort to optimize lung inflation. But high frequency ventilation remained relatively stagnant. We early on grasped the importance of the open lung strategy with high frequency ventilation, but conventional ventilation in the meantime advanced with development of synchronized ventilation, volume targeted ventilation, waveforms. The importance of open lung strategy with conventional ventilation was recognized. And so more recent studies no longer showed clear benefits, and efforts to do individual patient level meta-analyses did not identify any subgroups that clearly show advantages of high frequency ventilation. Yet in very experienced hands, it works well, and there are centers that use high frequency ventilation as the primary mode of support. But the risk of hypocapnia has clearly been an impediment to widespread acceptance, including my own. I don't use high frequency as a primary mode because I'm not always at the bedside. And it's really easy to overventilate because, as you know, tidal volume, the CO2 elimination is related to tidal volume squared. So even small increases in tidal volume can really lead to overventilation. So for that reason, high frequency has remained largely a rescue technique, but this may change because we now have some newer technologies. Everybody's familiar probably with the Sensormedics 3100, which is an antique device introduced in the 1980s. It's noisy. It doesn't do anything but high frequency, and it can't measure anything. The machine doesn't know if there's a cork at the end of the circuit or a patient. So that's a problem. But we do have other devices. This is one of them, but there are other high frequency ventilators that have these capabilities that can generate, that can do both conventional and high frequency. They use a conventional ventilator circuit, a stiff one, but more easily managed. They're quieter and they can measure things. And with the Draeger oscillator and a few others, you can measure, you can maintain, not only measure tidal volume, but you can use volume guarantee, which is really, for me, a game-changing innovation. It's been available in the rest of the world for some time, but it's still not approved by our Food and Drug Administration. Which is rather unfortunate. Volume targeted ventilation with high frequency is analogous to conventional. Tidal volume is measured, averaged over a few cycles because of the high frequency. It's compared to the target, and the amplitude, the pressure amplitude is adjusted to keep at target tidal volume. Then you, of course, have to set a limit, just like with conventional volume targeted ventilation. And of course, the mean airway pressure is still manually controlled. So in order to hopefully get the FDA to approve the study, we conducted a large multi-center trial a couple of years ago in order to have this device now be able to do high frequency even in the United States. And it was a study that used historical cohort comparison for a variety of reasons. And these were prospectively collected. And what you can see is that the outcomes were quite favorable. We were not seeking to show that the device was better. It was a non-inferiority trial, but all these important outcomes favored the new device. It maintained very stable CO2 over the first 48 hours and beyond. We used a frequency of 10 hertz. Perhaps today I would have used 15. So the tidal volume we used was a little bit over 2 initially and came down to around 2 ml per kilo. That's consistent with what's been observed otherwise. And importantly, it worked remarkably well. We looked at thousands of cycles, and 93% of the time in the raw data, the measured tidal volume was within 0.1 ml of target. 6.4% of the time it was, it was a little bit above target, below target. And the reason for that in a significant number was that the clinicians failed to adjust the amplitude limit. So the machine couldn't do what it was trying to do. When we eliminated the user error related tidal volumes, it was the percentage went up to 96%. So it really works incredibly well. So to summarize, prevention of lung injury begins in the delivery room with careful stabilization, use of CPAP, and avoidance of excessively large tidal inflations. Non-invasive support is the best way to avoid lung injury. Avoiding volutrauma is best done with volume-targeted ventilation, with different kinds, but volume guarantee is the prototype and most widely studied. Ensuring optimal lung inflation, the open lung concept is critical in reducing lung injury. And again, one size does not fit all. You need to do individualized patient care following important principles. And hopefully better devices are coming to our NICUs, even here in the United States, hopefully. And that's what I have for you. Thank you very much for your attention. This is what you do when your funding runs out. And if you want to read more about it, this is the textbook that describes a lot of this in far more detail than I can in 30 minutes. So that is all I have. And if we have time for a few questions, I'll be happy to field those questions.
Thank you very much, Professor Martin. It was quite enlightening about the lung protective strategies in the conventional and the high frequency ventilation. I'd like to ask the audience, how many of you have the ventilators with volume guarantee? Can you raise hands? I think it's quite a bit. So, but there must be so many places where these volume guarantee ventilators are not available. But I think it has been quite nicely shown that there is a lot of evidence that the volume guarantee actually helps in decreasing the incidence of the BPD and many other morbidities. Professor Martin, can you tell us about how do we in the delivery room, how do we control the volume? If we have to intubate and ventilate, is there any way where we can, because they say that even 4 to 5 breaths, invasive breaths, which are not controlled can cause a lung injury?
Yeah, that's a great question. So we know that the self-inflating bag tends to generate excessive peak pressures and therefore tidal volume. So using the T-piece resuscitator is one way to minimize lung injury. It's also been shown that relying on visual inspection of chest rise is not terribly reliable in terms of achieving or accurately estimating the tidal volume. So there is actually a small company that's been trying to has developed a prototype of volume targeted resuscitator called the Next Step. It is not commercially available yet. It is being studied and seems to be performing as hoped for, because of course we don't typically have the ability to measure tidal volume immediately in the delivery room. There are means of doing that and you certainly can put in a flow sensor in line with your T-piece resuscitator and measure tidal volume and monitor it and make adjustments in your pressure. But this device would do it automatically, and I think that's the next, indeed the next step in the delivery room care, where we can try to avoid that, because compliance changes quite rapidly in the process of initial stabilization. As you know, once you the initial first breaths may require fairly high pressure, and very quickly after that it needs to be reduced. So so that's important. There's a study being, I think, proposed at this point that seeks to demonstrate that immediately after intubation, employing volume targeted ventilation in the delivery room using a standard neonatal ventilator might be beneficial rather than continuing to use the TPs during the initial stabilization. So there are some approaches, but they're not easy to do. If this device, the next step, becomes commercially available, I think it would be a real game changer in terms of making it a lot easier to avoid the problem. Of course, we have to deal with, initially, most babies are not intubated. The positive pressure is being delivered via face mask and leaks around the face mask. The technique of the resuscitator needs to be meticulous. And again, there's evidence that using a physiologic monitor during resuscitation improves performance by allowing the clinician to recognize quickly that they have inadequate seal and correct that. So there's a lot going on in the delivery room resuscitation area in terms of research. Our Australian colleagues have done a lot of that work, and there's more to come. That's a whole other lecture. I had only 30 minutes to cover everything, so couldn't get into enough detail.
Thank you. Do we have any questions from the audience? Yeah, can I just ask you one more question? What is the maximum PEEP which we can go towards when trying to open the lung? And also, can we use an X-ray chest to assess the lung volume and to see where exactly the lung volume is, whether that has actually opened up or not?
Yeah, those are important questions. And the chest X-ray is not the best tool. It's a tool. It's best we have most of the time in terms of assessing visually the lung volume. But technique is important. If it's not centered well, if it's centered over the belly button rather than over the chest, the dome of the diaphragm projects differently. So rib counts only take us so far. You need to also look at the lung parenchyma in terms of is it well aerated or not so much. So it's not just diaphragm position, but for most of us, that's the best we have. The electrical impedance tomography is a tool that's hopefully going to become more available in the reasonably near future. As to how high a PEEP, so most of the time you don't need to go extremely high because surfactants work and improve compliance. And again, it depends on the scenario. So if we're talking about initial stabilization of a preterm infant, usually we don't need to go certainly higher than 8. Occasionally, I have gone up as high as 10 on rare occasions. If you give surfactant early, if you give surfactant essentially immediately after intubation, then you will rarely need to do a lot of aggressive lung volume recruitment because the animal-derived surfactants we now have available really improve compliance and aeration pretty quickly. But in some scenarios, babies intubated in the delivery suite and then moved to the NICU, and the surfactants only administered maybe 20 minutes later, 30 minutes later, which is probably still reasonable. But in the meantime, then you probably do need to use a higher level of end expiratory pressure. There is a study currently underway or having just started, the POLAR trial, that is looking at dynamic PEEP. So having shown that the sustained inflation approach was not the best way, and based on some animal data, David Tingay designed this POLAR trial. Several of us here were also involved with that. And the concept is to titrate the PEEP upward during the initial stabilization. So not necessarily intubated, but rather CPAP approach. And so the control arm is going to be static PEEP of whatever people choose to use, 5 or 6 as a starting point. And the intervention arm is going to look at escalating the PEEP stepwise until oxygenation improves. And so in that scenario, you might easily go up to 8 or even 10 centimeters. Again, briefly, the key is not to I think where we fall down and where we many people have had some bad experiences, and some studies show potential harms of high end expiratory pressure, is because it remains high. Okay, and again, once the lungs are recruited, once the alveolar diameter increases, what PEEP was necessary to open them up becomes excessive. So it's easy to show bad effects of high PEEP if you don't back off once the higher PEEP achieved its intended goal, which is to open up the alveoli. Right. So you may briefly need to go up to 8 or 10, but then quickly back off once oxygenation improves and lung aeration improves. That's the key.
So is that the way we bring the ventilation towards the expiratory part of the hysteresis? So you have shown that we have to, for optimal ventilation, it is good to ventilate in the expiratory curve of the PV loop. So we should first increase the PEEP and then gradually come down based on the oxygenation.
Exactly. So the Dutch investigators did a nice study a few years ago using oscillatory ventilation, where they demonstrated this stepwise increase with the oscillator directly mean airway pressure. And they do this recruitment maneuver before giving surfactant, arguing that surfactant distribution is improved if you put surfactant into a recruited lung, which is true based on experimental data. So they start at a lower distending pressure, typically around 8 or 10 centimeters, and then they progressively increase in 2 centimeter of mean airway pressure increments every 2 or 3 minutes, as long as oxygenation continues to improve. When they are able to wean the FiO2 down to less than 25% in their case, most of us are happy with less than 30%. They consider the lung fully recruited, and at that point they consider that the quote unquote open lung, and then they decrease the distending pressure in 2 centimeter increments, or decrements rather, until they just begin to see a deterioration in oxygenation, and they call that the closing pressure. And ultimately, they go back up 2 centimeters, and they're happy that that is the appropriate distending pressure at that time. Now, it takes some period of time to achieve that, and then they give the surfactant. So most of us don't do it this way. Most of us give the surfactant right away. So, but they illustrate very nicely the concept and where they end up. So just to give you the numbers, the mean airway pressure in these surfactant deficient babies at maximum pressure, the open lung, was about 20 centimeters mean airway pressure. And then the closing, the pressure was about 10 to 12, somewhere in that region. So much lower, right? You end up at a much lower pressure than you initially went up to, illustrating the concept that once the lungs open, it requires much less pressure to maintain the lung volume. And that's where you're sliding down the expiratory limb, finding the spot just above the closing pressure.
Thank you very much. And finally, one last question. Do you use ultrasound to help in the lung recruitment? What's your opinion about it?
So lung ultrasound is really something that's coming along and becoming more widely accepted. It was initially misunderstood, and many people were like, ultrasound of the lung, air doesn't conduct ultrasound, what are you talking about? But now I think we have pretty strong evidence that it can be useful. We have not done much of it in the United States because of some logistical and territorial and medical legal concerns. But from what I understand, and so Daniel De Luca and Francisco Raimondi have done a lot of work in that area, and it seems to be a useful tool, but I don't have personal experience with it. But I think we will be, many of us will start using it in the near future to help understand this state of inflation, state of aeration of the lung.
It's true. Thank you, sir. Thank you, Dr. Martin, for a wonderful talk, which was very enlightening. Thank you so much.
Thank you, Professor Martin Keszler, for giving valuable insights on the topic. We would also like to extend our gratitude to the moderator of the session, Dr. Ravi Shankar. Thank you, sir.